doctor speaking on small is tough, and let's see.
Small eyes can be classified according to anterior chamber depth and axial length. This video will demonstrate the challenges found in two cases: extremely short axial length and a small ACD, namely the nanophthalmos. A unique complex case, a software engineer by profession with high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal sized cornea and a very shallow anterior chamber, and gonioscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG-PI in both eyes. Her dilated fundus examination revealed heaped up optic nerve head and retinal vessel tortuosity with an attached retina in both eyes. OCT macula was normal in both eyes. A detailed imaging was performed on tomography, optical biometry, and a corneal wavefront and an ocular wavefront analysis was done. What the test revealed was indeed unique and surprising. Her white-to-white diameter was 10.7, her ACD of 2.68, and her lens thickness of 4.27 in both eyes. Her axial length in OD was 14.85 and OS 14.89. Her average keratometry in both eyes was 56, a very steep cornea. IOL power calculation by different formula varied from 49 diopters to 65 diopters. B-scan showed a thick chorioscleral complex, 2.06 mm in the right eye and 2.23 mm in the left eye. On conclusion, it was an extremely short eye, a very steep cornea, a very shallow anterior chamber, and a normal lens thickness, almost 1/4 of the whole eye. A thick chorioscleral complex, so a nan-ophthalmic eye, or shall I say a PIC ophthalmic eye. Set the wheels rolling, made many calls, wrote emails, asked, discussed, thought, and reviewed literature. The patient was planned for clear lens extraction. Decided to go ahead with a customized hydrophilic foldable IOL of 65 diopters to be injected through a small incision of 3.4 millimeters. The challenges faced is IOL power calculation, manufacturing a customized high diopter power IOL, and injecting the same safely through a small incision. Well aware of the various complications known in nan-ophthalmic eyes, adequate precautions were taken before, during, and after surgery. Patient taken up for femto, rhexis, and a 4-quadrant division of lens performed. A 0.75 mm side port incision made and a gentle release of the aqueous, replaced by an OVD. Using a microrhexis forceps, the CCC was rasped out. Bimanual IA used for aspirating the lens material. Globe not allowed to collapse because of the use of the OVD. Main incision of 3.4 mm made. 65 diopter, highest ever IOL manufactured, was loaded, placed in the cartridge, and then injected. Loaded the hydrophilic IOL.
Significant amount of pressure
Needed to push the 1.9 mm thick IOL through a 3.4 mm cartridge. Precaution taken to not let the globe collapse. IOL placed in the bag and the trailing haptic dialed into the bag. Suture placed, bimanual IA done for OVD removal. Air placed. Post-operatively, overwhelmed to see the first day post-operative visual acuity of 20 by 60 and a refractive error of -1.5 spherical with a -1.75 cylinder at 20. On conclusion, a comprehensive approach for such challenging cases like nan-ophthalmos or micro-ophthalmos can have good visual outcomes. Thank you.
Thank you. So, Dr. Chi, would you like to comment on this?
was a beautiful video. You really thought through the problem and you planned for this patient. But you didn't tell us what type of anesthesia this patient was under.
Topical. She's 21-year-old.
Okay, because if the patient starts to squeeze or struggle,
Yeah.
you have an
But
expulsive
she's very, very
hemorrhage.
smart. She's an engineer. I wonder how she studied with a +12. She's very cooperative. And you'll be shocked if I tell you the end. At the end of now 3 months, she had the 1.52 became -3 with a -2 SIL. I went ahead and did a surface treatment because her keratometry was 57. And now she's a -0.75, a 618 unaided. She's extremely happy.
Yeah, I was going to ask you whether you targeted plano or what you were targeting.
I don't know what to target because there is no formula which accepts. We try any formula and you try to put in a 57 diopter, it just does not accept a calculation.
Yeah, so my question is, did you do a UBM to
Yes,
have a
we
look,
did a
see
UBM,
whether it's
yeah,
an
yeah.
effusion? Because very often, these really small
Yes.
eyes is hard to predict because you
Yeah.
can't even predict the final effective lens position.
Yeah. So we did a UBM and that's how we got all the sizes. Plus we looked for that and we looked at the scleral, the thickness, choroidal thickness. So we did all of that.
Yeah, because I've had a patient
Yes.
that, was exactly the same,
Yeah, yeah,
14.5. And at 3 months, she suddenly became myopic. And even though we didn't see an effusion, we put her on atropine and everything went back.
So I maintained atropine for her for a long time.
Okay.
I didn't stop atropine.
So you
For
put it right
almost
from the
2
outstart.
Yeah, 2.5 months, 3 months she was on atropine.
Kumar, just a quick thing on the anesthesia.
Yeah.
It's great to do topicals and everything, and it's not really a matter of getting away with it in these
Yeah.
kind of patients,
Yeah.
but doing these patients under a general anesthetic is actually gives you a huge advantage, and the simple reason for that is your anesthetist can adjust the choroidal gas to adjust the choroidal blood flow, the PCO2 to adjust the choroidal blood flow, and it gives you amazing control over these patients in terms of the AC shallowing and all the other issues that we get with these kind of patients. So, I mean, it's something I would suggest.
You're right,
consider.
absolutely, Milind. There's no doubt about what you said. But my only fear was because I did a femto. So I would have to shift the patient from that table to this table. That was the only thing for this. And she was very, very cooperative. But you're right. I mean, there
I'm
is
sure
no doubt.
you do a manual Rexus better than your femto.
Thank you, Dr. Kumar.
Thank you.
I want to comment what
Sir.
was the it was very challenging case. What was the post-operative anterior chamber depth?
Yeah.
Because something you told
Yeah, pre-op.
pre-op you told it was less,
Yes.
and post-operative what was the
So-
this and what was the intraocular pressure in the long term or short term whatever.
Till
you
now,
have.
it's about 4-5 months up. The pressure is normal. As far as the post-op ACD, I've not measured, but the thickness of the lens is 1.9. So we have to subtract 4.7 was the pre-op lens thickness. The ACD was 2.68, and now I put in a 1.9 thick IOL. So that would be the post-op anterior chamber depth.
Thank you, Dr.
Thank
Kumar.
you.
Thank you, panel. Can we have Dr. Shilpi? Thank you.